Hello, everybody. It is Friday, January 15th, 2021. Welcome to the end of yet another long and, if I may say, excruciating week of news. Dr. Heather Johnson and I are going to be talking today about women's health, COVID-19, and everything under the sun that you want to ask us about vis-a-vis the pandemic and in particular, women's health. We'll talk about menopause, but you don't have to be menopausal to be joining this conversation. So first of all, I'd like to say thank you to Dr. Johnson for joining me. She's a practicing OBGYN in Washington, D.C., and is an author of a number of books, including a recent book that's awesome and perfectly timed given the issues we're seeing in women's health. It's called What They Don't Tell You About Menopause. So Heather, thank you so much for joining us, and thanks for joining us in the audience here today.
Great to be here again.
Yeah, it's fun to see you again. We did a little ditty earlier in the pandemic and talked a lot about women's health. And, I think women's health is often underappreciated, underrecognized. And what I really love about your book is that, it's like, it is everything you need to know about menopause and not more. It's not this long tome with a lot of like medical jargon and too many pages. It's exactly what you need. It's lean. And, people are mystified by menopause and, it's exactly what you need. In fact, someone posted on one of my social media feeds when I was promoting this conversation saying that this is great timing. I ended up getting a COVID test because I had a hot flash, and it turned out it was a hot flash and not COVID-19. So, there are overlapping symptoms there that we can certainly discuss. So Heather, tell me first, just to start out, like how are your patients doing? You see women of all ages, but how would you say on par people are doing in the pandemic, mentally and physically?
Let's say well and not well.
Mm-hmm.
I have a lot of patients who are fortunate enough to be able to work remotely. The majority of my patients, so they feel safe.
Yeah.
They still have their salaries and they can go about their daily business, but that daily business has changed tremendously. And it sounds whiny to say, I can't do my routine, I can't do my exercise, I can't, but when month after month after month of that goes on, there's just lots more depression, lots more frustration, and the poor moms of younger children who are working from home with their spouses who have now invaded their space, and now their children needing supervision as well. It's been stressful. And
yeah, I think that's right. I think it's stressful no matter what age you are. If you're younger and have school age kids and you're trying to homeschool, work your job, manage the house, and try to have any shred of sanity, that's hard. If you are older and you're alone or not, and you are dealing with perhaps underlying health conditions and all the stress of the world, I mean, there's this right now, as there's this kind of toxic mix of political unrest and racial injustice and a pandemic that's almost killed 400,000 people in this country. So, I'm seeing this as a pandemic of a virus, but it's also a mental health crisis. Our mental health is taking a hit, no matter who you are. Even if you haven't had COVID-19, you're probably experiencing some sort of trauma, grief, loss, anxiety. At a minimum, your routines have been turned upside down, and life as we knew it is not there. And there's grief about that. Not to mention there's grief about people who have lost their lives in the pandemic, either from COVID-19 or otherwise. So, I think it's a very, very hard time. And doctors right now, I feel, have somewhat of a obligation to kind of make sure we're addressing people's mental health in addition to their physical health, which is something I know you do in your office all the time. I mean, you're not there simply to check people's pap tests and pat them on the back. You're actually addressing, the physical symptoms and the mental health symptoms that come along with being a human being. When we think about menopause for a second, what are some of the things you're seeing, not just now, but before the pandemic, that are in that bucket of like mental health? Like, what are some of the things you counsel patients on when it comes to menopause, when it comes to like wellness, well-being, and mental health, and how has that changed or not in the landscape of the pandemic?
Well, sometimes in some ways it's actually easier to see because you mirror the different anxieties and the way your body is made to feel. You don't get sleep at night when you're having hot flashes, subliminal or real, and it builds up over time and you're exhausted and depressed. But then it becomes clear to people that that is a health issue, even if you're not going through menopause, that you do need sleep, you do need rest, you do need exercise. The anxieties that are associated with this pandemic and the social unrest and everything else are thrown on top of that, but somehow it helps people see a little better.
Yeah.
That it's something that they should tend to.
Yeah, I mean, I think that's what I'm seeing also with my patients, is that people who kind of got away with not sleeping enough, or got away with not eating, 3 solid meals a day, or got away with kind of burning the candle at both ends at work and at home, without the normal coping strategies that we have in our regular lives, like going to the gym, seeing friends, giving people hugs, even commuting, and seeing people at the office is a way of kind of like managing our mental health, in terms of like just having routines. With those things gone and stripped away from us, I think you're right. We've kind of laid bare the problems and that we have, and the essentialness, if that's a word, of basic biological needs being met. So, I'm talking with people every day about, at a baseline, at a minimum, you need to meet your biological needs. Prioritizing sleep, 7 or 8 hours a night, if possible. Now, when I say that to people, they sometimes throw their head back laughing, thinking, are you kidding me? That's ridiculous. But it's a goal, getting 3 meals a day. It doesn't matter always what you eat. I mean, it does matter what you eat, but of course it matters what you eat. But skipping meals is not good, and it promotes anxiety and also can promote hot flashes. Trying to eat healthy, minimizing caffeine and alcohol, which of course can accentuate hot flashes, and then working on, getting some routine exercise. It doesn't have to be fancy. It doesn't have to be in expensive, gym clothes, but, something that involves movement most days of the week, getting in nature. And then of course, because nature is good for us, it helps us tamp down the adrenaline and stress hormones that we naturally feel when we're under stress. And then, working on mental health, asking for help, reaching out to your doctor, reaching out to a therapist, thinking about how to mitigate anxiety and fears, how to tease away, what is a anxious thought and what is a, rational thought. And that, for better or worse, we have more time on our hands now to think through how our brains work. And I'm encouraging people to do that in this crazy time. It's really an investment in our whole health to think about how we react to the external world.
Yeah, I do see some almost pandemic fatigue.
Yeah.
From the fatigue in that, initially people were making time to go for long walks. Of course, it started in the spring when the hours were long and they could do it in the morning or in the evening. And they were thinking, well, I don't have to commute to work, so let me walk in the morning. But that seems to be fading. And the Zoom creep has gotten higher. Jobs are saying, well, you don't have to commute, so let's have a Zoom meeting at 7:00, or you don't have to drive home, so let's do a Zoom at 5:30 as well. So we have to watch those things that are creeping into our lives.
I think that's right. I'm encouraging the audience here to ask questions. Happy to answer any questions. Can I ask you a question about, like, what are you advising your patients who are pregnant and also your patients who are breastfeeding in terms of getting the vaccine? That is top of mind for everybody right now. And, I'd be interested in your thoughts on that.
I actually just had a telemedicine with someone before this about that very same question. She and her husband are thinking about getting pregnant in the next, few months. And the thought, her concern that maybe she should wait until after she had the baby to get the vaccination. And, my response, she has the opportunity at work to get it now. And my response is, go get it. I mean, first of all, you're not even pregnant, but second of all, even if you were, go get it. You don't want COVID when you're pregnant. You don't want COVID, period, but you definitely don't want it when you're pregnant. It is not a live virus. It cannot infect you, so it cannot infect your baby. There are other vaccines that we recommend in pregnancy, like the flu vaccine, and the Tdap vaccines, and they've been proven to be safe. The difference with the COVID is that we haven't done the studies yet, so you can't safely say it's safe. And we won't know for a while with that, but if one of our partners got it like 5 days before she delivered her first baby. So American College of Obstetricians and Gynecologists does not officially say that you should take it and that it is safe, but because they don't have the data, but they then step aside and say, make your decision, and there doesn't appear to be a reason to be concerned.
Yeah, as you said, the data, it's not that it shows that it's unsafe, as you said, it's just that not enough pregnant, my understanding is there weren't enough pregnant and breastfeeding women enrolled in the study to even know the answer to the question. But if I'm also right, it stands to reason that it wouldn't have any safety effect, negative safety consequences, although of course we need to see that play out. And of course, pregnant women with COVID-19, I think, you tell me, tend to have poorer outcomes. Is that right? With coronavirus infection itself, with COVID-19?
Well, just in general, pregnant women get viral infections, get pneumonia, especially the flu, which is one of the reasons pregnant women are our top priority during flu season. Pregnant women and over 65 are pretty much, in the same category there. We want to protect them from the kinds of diseases that could land them in the intensive care unit.
Right. And then for nursing mothers, I mean, my understanding is the reason I breastfed my kids for I guess it was a year each, what a labor of love, as many women do, was to give them, antibodies through breast milk. And so it stands to reason that you would want to have the vaccine to be able to then confer that immunity to your child. But what are you seeing and what are you hearing? What are you advising patients regarding the vaccine and breastfeeding?
I've actually seen some patients continue breastfeeding longer than they otherwise would have, which is nice because they were hoping to pass on antibodies. So that's good. The few children of healthcare workers who've gotten the vaccine, that has happened. But again, the same with the pregnancy. We don't have any reason to believe it would be harmful, and we have lots of reason to believe it would be beneficial. We just can't officially say it. But
That's right. And it will be official at some point, right? I mean, we have enough people who are getting the vaccine who are pregnant and breastfeeding. We'll see what the safety implications are, just like we'll see with the general population. We know that the vaccine is safe in the short term because it's been studied in tens of thousands of people. You and I both know that there are two main buckets of side effects that are up front with the vaccine that are expected and normal and not a reason to be afraid or not a reason to not get your second dose. One is pain, swelling, redness at the site of the vaccine, which I had a little bit of that with my first shot. And then the other is transient body aches, malaise, headache, and that is all normal. That's your immune system working, and that is normal. But of course, we won't know the long-term safety until the long-term exists. The virus has only been around for a little over a year. But so thank you for that. There's a great question coming in, and this is one that I'm getting quite a lot. How does one distinguish between nighttime sweats that are either menopausal or anxiety related or something else versus COVID-19? And how do you know whether night sweats even, let's say you test negative for COVID-19 and we know it's not COVID-19. How do you think about night sweats and what it could be?
Well, I mean, and that's a good question. And anybody who's not had the pleasure of having night sweats doesn't know how bad it can get. I remember my first one that was bad. I dreamt that I had malaria. I just was that hot and that sweaty. And so at least initially, yeah, it could be the same thing. But for COVID, you get sick for a certain period of time and you have other symptoms as well. For menopause, that lasts a lot longer. But initially, yeah, you would, if it goes away in the daytime and it's only there at night, that's probably a sign that this is a hot flash night sweat that you're having rather than COVID.
And there are certain medications that commonly promote night sweats or hot flashes. So the SSRI class of medications, I mean, that's a very common side effect. So Zoloft or sertraline, Prozac, fluoxetine, Lexapro, escitalopram, Paxil, paroxetine, Celexa. So all of those SSRI medications can promote hot flashes and night sweats. So, and I have a number of patients on those medications. And, you know, I tell them not to worry if they have night sweats or hot flashes, particularly if they're not even at the age where people do go through menopause, which is, you know, typically, I think it's like, I mean, not I think, I know it's between like 49 and 54.
48, 52, yeah.
Yeah.
Sort of the average, yeah.
Yeah. So if you're 30 and you've been on and you're recently on an SSRI for anxiety, for example, and you're having night sweats, that's pretty much probably not menopause. The other things I'm sure you tell people about night sweats and hot flashes is that there's certain substances that we consume that can promote hot flashes and night sweats. So sugar, caffeine, red wine in particular. I mean, I certainly know that when I drink red wine, I wake up with like a horrible taste, you know, dry mouth and sweaty, and it just, yet I forget and then drink red wine again another day. So there's certain medicines and there's certain substances that can certainly do those things. And then of course, infection can cause night sweats, and, you know, like a urinary tract infection or, you know, blossoming sinus infection, the flu. But of course, it's best to talk to your doctor if you suspect those things are going on. Heather, I'll ask you this question. Are there any over-the-counter medications that help with menopausal symptoms? Like, you know, we as doctors know that hormone replacement therapy is very much appropriate for the right patient, that it's not taboo. I think a lot of people think that HRT, hormone replacement therapy, postmenopause is verboten, when actually we use it, you and I do, for many patients. But if you can avoid hormone replacement therapy and use over-the-counter medications to manage these symptoms, I recommend it. What do you tell your patients in terms of supplements, vitamins, and that kind of thing?
Yeah, so there are multiple over-the-counter things that at worst couldn't hurt, that seem to work for a number of people, at least with mild symptoms. Long-term controlled studies may or may not necessarily bear that out, and there is a good placebo effect. But there are a lot of things with soy based in them. Ginseng, Danquay, Estrogen is one of the ones.
Estrogen is, yeah, I've heard people take that ESTROVEN,
yeah,
which people worry. They ask me, does that have estrogen in it? And the answer is no. It's just a play on words.
It's a play on words, and that, but I think it has a soy base, and the soy chemical structure and the estrogen chemical structure, you know, somewhat look like each other, and so that's how that's worked. Black cohosh. For most of these things, you know, I actually suggest to people you try these first.
Yeah.
And if they do work, then that's just wonderful. And if they don't work, well, then you move on to other things.
So one of the supplements I recommend to people commonly, and maybe this is what I'm interested in your thoughts, is evening primrose. Does that? Yeah. I mean, anecdotal evidence there, but I mean, what do you think about that?
That's an oldie but goodie, and again, people. I've not done the particular studies, but that seems to please more people than some of the other suggestions. It's pricey,
Oh, is
but
it?
yeah, well, if you get it at Whole Foods, but everything is pricey there. So it's, but it's a little bit more than some of the other things.
Interesting.
Yeah.
Yeah, and even if some of these things act via placebo effect, like we'll take it, right?
You're still sleeping.
If you're sleeping, it doesn't matter if it's a placebo effect. We love the placebo effect. It's a beautiful
exactly
thing.
Right. That's exactly right.
Right. I'm also, I recommend, so for people who have difficulty with night sweats, hot flashes, and then their resulting sleeplessness and then fatigue in the daytime, and, then they drink more coffee, and then the coffee makes them have more hot sweats and night sweats. To try to break that cycle, I'm often using a prescription gabapentin. Do you use gabapentin off label for?
I have people on it, and I've not personally had a lot of good experience with people who had very, very bad hot flashes. I've used it more, and this may be a prejudice on my part and not fair, but I do use it more with people who have breast cancer, or they've had blood clots, or some reason why they absolutely cannot take estrogen, and they absolutely are suffering.
Yeah. So let's talk about estrogen for a minute, and if you talk to enough doctors like you, and also some of my my colleagues who do like urogynecology, the specialists in pelvic floor function and continence, a lot of people say that it's under advertised, and that it's not, it's because it is safe in the right person, that we should really be talking more about it, and patients should be asking about it if they are having symptoms of not enough estrogen, aka menopause. What are your thoughts about estrogen and progesterone?
I think urogynecologists have become much more aware of it. They are, yeah. And I think it's because they are urogynecologists, and maybe some of the urologists are also now learning. And I've found some of my older patients have been placed on it, or recommended to ask me about starting it by their urologist. So that makes me very happy, especially when it's vaginal, because it's not systemic.
Yeah, so vaginal estrogen, just so people know, is something you can take post menopause. It's either a tablet that you insert intravaginally, or it's a cream, and it's topical, so it's not absorbed in the bloodstream like oral hormone replacement therapy.
Yeah, and it does a very, very good job with vaginal dryness, pain with intercourse, urinary frequency, predisposition to urinary tract infections. So
yeah, I prescribe it quite a lot when people, so you see this all the time, I see it too, is you'll have a 50-year-old woman who suddenly, she hasn't had urinary tract infections since college, and then all of a sudden is getting frequent UTIs, and that's often because the estrogen levels have dropped, and your sort of vaginal immune system isn't able to clear bacteria like it used to. You put that person on vaginal estrogen, and then they don't get UTIs anymore, and they're not dry, and their sex life is better. They're not having pain with intercourse. So it's a wonderful thing. I mean, people are nervous, however, about even vaginal estrogen, but for the right patient, I tell them it's very, very, it's very safe.
Yeah. The unfortunate thing is that it's become very expensive. The Estrogen, which had been my favorite, estrogen ring, because you put it in and it lasts for 3 months. You don't have to put goo or anything else in there. The copay has gone in the last few years from $20 to $900.
Are you kidding me?
For a 3-month thing. So
that is just like, that's just evil.
It's $2,700 a year, and with the frequency of intercourse going down, many women are just, many women just can't afford that, period. But
right,
they could. And part of the reason the copay is that way is because the insurance companies are calling it a lifestyle medication, and so
which is that is like, I mean, not to get into this is just anti-woman thinking, right? I mean, it's like, Viagra is covered readily by most insurance companies, and then estrogen isn't. I mean, there's just, clearly a double standard when it comes to women's health. Yeah, that's a crying shame.
It takes two to tango. So if it's his lifestyle, it should be hers as well. But $900 is.
That's prohibitive.
Yeah.
It's prohibitive. So then, I mean, it sounds like you try to get creative with other estrogen formulations. So there's a vaginal estrogen, which is intravaginal with cream or an insert tablet inserted intravaginally, right. Or the ring, which you just described, which is super expensive, but if somehow you magically get it, is good for 3 months. And then there's the patch, right? The estrogen patch, which is nice because it's not absorbed, it doesn't go through the liver.
Right. But that is systemic, so it does affect breast and other things if people are trying to avoid that. But yeah, the patch is also typically much more expensive than the oral.
Yeah.
Again, the insurance company co-pays are much higher.
Yeah. I think everybody wants to avoid breast cancer. It's just as with every decision we make in medicine, the decision to put someone on hormone replacement therapy versus not is a risk-benefit ratio analysis. We think about what are the risks to this unique person in front of us. What is their family history like? Do they have breast cancer in the family? Do they have ovarian cancer in the family? Have they themselves had breast cancer? And if they themselves have had breast cancer, then estrogen is out. But if the answer is no to a whole lot of these questions, and they have no risk factors for thromboembolic disease like venous blood clots, they're not a smoker, and there's a whole other host of things we go through in someone's medical and family history, and they stand to benefit from estrogen, meaning they have debilitating symptoms of menopause, hot flashes, night sweats, mood instability, pain with intercourse, and other symptoms that we can't mitigate with the over-the-counter things that we already gone through. Then the risk-benefit ratio analysis ends up pointing towards using hormone replacement therapy. And I see people who are very, very happy, and it can be a lifeline, a life changer for people.
A lot of women don't understand, and they're surprised when you speak to them about it. The vast majority of women who get and die from breast cancer never took hormones.
That's right.
So it's especially now, since the Women's Health Initiative, when most people no longer take hormones. Prior to the Women's Health Initiative, I'd say a large number of people did, but women are still getting and dying from breast cancer, and it's not just from hormone replacement therapy. That's
such an important point.
Yeah.
It's such an important point. I think I've been talking about this with people recently about how, anxiety tends to stick to the data that can inform like a worry narrative that you might have.
Yeah.
You know what I mean? So people think, okay, I know someone who took hormones and they died from breast cancer. Therefore, I should not take hormone replacement therapy. Right. We have to look at the data. We have to look at your unique health situation, and we have to look at, your anxiety and how that might distort your thinking about making an important decision like that. But you're right. There are a lot of other things that can promote breast cancer: genetics, environment, a lot of those things we don't actually even know, we haven't identified. But we also have really, really good screening tools for breast cancer, right? I mean, yes. Mammography is more and more sophisticated. And if you get a mammogram annually, and then get your breast exam, I try to have people get a breast exam twice a year, once with their gynecologist like you, and once with me. So, and then ideally stagger it so that you're getting one in, say January and one in July, 2 breast exams and a mammogram.
Yeah, exactly.
Then you can't have enough breast exams. Then breast self exams can be good too.
Mm-hmm.
So someone's asking here about osteoporosis. Osteoporosis medications for a 56-year-old woman who's just now going through menopause and whose recent DEXA scan revealed osteoporosis. So, yeah, I mean, osteoporosis is, as just to define it, it is a thinning of the bones that is commonly a result of the hormones that we normally have circulating in our bodies dropping down. So being postmenopausal puts you at higher risk for osteoporosis. There are other things that can put you at risk for osteoporosis, like a family history, being underweight, having gone through stretches of time in your youth where you lost your period, like patients who are gymnasts or runners or had anorexia nervosa. But osteoporosis medications are definitely worth considering if you have a T-score of minus 2.5, which is the cutoff for osteoporosis in your spine or your hip, which are the two sites we measure. And sometimes hormone replacement therapy actually can help the bone density scores. That's not the first thing we think of to treat osteoporosis. The first thing I think of is making sure you're getting plenty of calcium in your diet, making sure your vitamin D level is nice and robust. You want to get that level checked with your doctor, making sure you're getting weight-bearing exercise. So, and then thinking about medication. And medication, in addition to, weight-bearing exercise, calcium, and vitamin D, can really make a difference. I mean, there are a whole host of medicines on the market right now for osteoporosis. The bisphosphonates are still first line, like Boniva, Actonel, Fosamax. So, it's definitely worth thinking about medications, but of course you want to talk to your doctor. I'm sure, Heather, you talk about osteoporosis every day. So what are your thoughts and advice to this patient who's newly diagnosed?
Yeah, I mean, pretty much exactly what you said. And one of the things that can contribute to that are premature ovarian insufficiency or menopause. And I wonder, if someone's in their early 50s, there may be some other reason why they've developed not osteopenia, which is bone loss, but osteopenia to the point that it's fracture, and that's a minus 2.5. And so I think the first question will be to discuss with her primary care provider, what are other risk factors I might have to have brought me to this point at such a young age, because that's young.
That is young. At 56, you're right.
And so, and if there are reversible causes, something's wrong with your thyroid or hyperthyroid, parathyroid, whatever, go for those first. But yeah, you can't ever get away from the weight-bearing exercise, calcium, and vitamin D.
Yeah, it's a really good point, because 56, you haven't had that much time to be postmenopausal to develop osteoporosis. So is there something else going on, like celiac disease, hyperparathyroidism, being underweight for many years? I see that commonly. I mean, a lot of people who don't have enough body weight on them get osteoporosis early. And so those are the things you want to think about, among others, when you're considering how to treat it, reversing the things that you can reverse before you contemplate medications. I'm just curious from, I talk about weight-bearing exercise to patients all the time for bone health, but also, for everything else, balance, stability, coordination, fall prevention, particularly in my older patients. When you're talking about osteoporosis specifically, what is your, how many minutes, how many days a week, what do you recommend for your osteoporosis patients in terms of the weight-bearing exercise?
I'm saying a minimum of 20 to 30 minutes, a minimum of 3 times a week.
Great.
I would prefer more, but that's your entry level.
And you're talking about for upper body, lifting weights
or push-ups or
planks
of any kind, planks, toes and bows, whatever those things that you can do. Walking, is good for the spine and the back, but doing a little something extra on the upper body, I think, is where women kind of fall down.
I think you're right. I mean, it's much, as two-legged animals, it's much easier to get weight-bearing exercise and lower body tone just by living our lives. But it's what I see all the time is women who develop weak upper bodies because they haven't actually worked on it, and that can affect posture and curvature. And if you don't work on your those muscles that sort of sit between your shoulder blades, it can affect your posture and can cause pain. So in addition to bone density, like the thickness of your bones, you want to make sure you're getting upper body strength for your posture and be able to open that jar, all those things. Someone's asking about ospina. Could you talk about ospina a little bit? I'd be interested in your thoughts on that, Heather.
Yeah, and I don't mention that, I think, very much in my book, and I think that's something that I should have recommended. There's a couple of drugs that are called, they're referred to as non-hormonal to treat postmenopausal symptoms. And technically they are not hormonal. They are not estrogen, and they are not progesterone, and they are not testosterone, but they're in this category called SERMs, selective estrogen receptive modulators, so that they act like hormones and prohormones in some parts of the body and anti-hormones in other parts of the body. Tamoxifen that people with breast cancer get is protective for the breast, but it is pro-estrogen in the uterus. And so this Osphena, and I'm blanking on the other ones.
Like Avista?
Yeah, they are not hormones in the normal sense, and they do help with some menopausal signs and symptoms. So that's the good thing. But you have to consider what it does to the breast or what it does to the uterus. And if you're doing it for vaginal symptoms, you're taking something oral and systemic to address the vaginal symptoms. Everybody's different. It's nice to have lots of tools in the toolbox. And so there may be reasons why one particular kind is better than another kind, but I just don't want people to think that they're not getting hormones, but they are getting a family of something that is hormone-like.
Yeah.
That doesn't make it bad, but if you think that that's what you're avoiding, the marketing is probably not as honest as it could be.
Yeah, that's really helpful. You know, it's funny. I see a lot of gynecologists who I work with prescribing vaginal estrogen. You know, but not as much Osphena. Like it hasn't like I don't see it as like popular right now.
No. And I'm not sure whether that's a prejudice that gynecologists have, and because we feel comfortable and safe with the estrogen, but it's been around for, I would say 7, 8, 9, maybe 10 years. And is it not popular because we're not making it popular, or not popular because patients have not been receptive, or I don't know.
You know what is popular is the IUD. You know, I mean, switching gears for a minute to, you know, postmenopause to, you know, premenopause, when people are using preventative measures to not get pregnant. You know, it used to be that everyone was on the birth control pill, and now the IUD is, you know, the most popular thing around. And they used to be a whole lot less safe than they are now. But I commonly recommend for my younger patients the IUD, even if they've and there was this misconception for a while that it was only for people who had had their kids, so people who have had their kids and then need to buy some time before they go through menopause. But it actually is completely safe, tolerated well, and appropriate for people who are like, you know, college students, 20-year-olds. So I recommend the IUD. I mean, do you have any reservations about it or any thoughts about it about the IUD?
I think it's Nobel Peace Prize worthy.
Oh, really? That's awesome. I love hearing that.
The difference, and you know, there's a lot of lingering concern because of the Dalcon shield, which was many, many, many years ago. And it had a design flaw. So the string acted like a wick that literally sucked bacteria from the vagina up into the uterus, and young women got dreadful pelvic infections resulting in complete hysterectomies and things. So the tendency after that was pulled off the market was to say, well, let's make sure she's had all her children first, and then we can give it to her. So it used to
be. And we can risk her life after that.
Yeah. Then it's, so if she gets infertile, so what? But the newer ones that are out, especially the progesterone containing ones, are so well tolerated. They make your periods light to absent. And, you know, if you put them in young people, a lot of inner city clinics and things are doing that. They can get out of high school without a pregnancy.
Yeah, I mean, the public health implications are huge, right? I mean, teen pregnancy is such an enormous problem in this country. And, you know, compliance with taking a daily pill is difficult even for the most organized, you know, 20-year-old. So I'm a fan. I love to hear you say that it's Nobel Peace Prize worthy. Yeah, great.
Freedom. It is.
It's freedom. It's freedom for women to live their lives and have more control when they want it.
Yeah, I have a lot of people who travel overseas a lot too, and you know, they're working in areas where they may not have the best, you know, sanitary conditions and things, or had a couple of people getting ready to start their residency who just like, I don't want to have a period for 4 years or 2.
Right.
or something.
Right.
And I do need birth control, so it's great.
Yeah, it's great. So I feel like it wouldn't be a talk about women's health if we didn't talk about sex, sex drive, libido. One of the most common things people are happy to talk about when I bring it up is sex drive. People are sometimes sheepish about bringing it up, but if you ask, as I know you do with your patients, when appropriate, people are often very delighted to be asked the question because there's some shame about having a low libido, there's some embarrassment, and then of course it's a private subject, but I think it's worth thinking about, particularly when I have an expert in front of me. But what I will say that so many women, particularly women who've been like long-term committed relationships and are monogamous, report low libido. And the first thing I almost always say to them is like, well, that is like, you're not alone. Like I can feel an auditorium of women who have this issue of low libido. And it's not something that necessarily indicates that you don't love your spouse or your partner. It's not, a black star on your resume. It is what it is, but it's worth troubleshooting. And for a lot of people, it's emotional. For a lot of people, it's about body image. For some people, it's about anxiety. Sometimes people, though, have physical difficulties with sex that makes them less inclined to have sex. So everything from muscle tension to vaginal dryness to other sort of physiologic anatomic challenges. So, tell me what I don't know if you have like a top 5 recommendations for low libido but tell me what your thoughts are about Heather, because I think people are always happy to hear some advice from a pro like you.
Yeah. Well, I have to say that, every woman thinks that every other woman is having wild and crazy sex. And every man thinks that all the other men are getting more sex than they are. And
isn't that true? Everyone thinks that the movies are real, that like that stuff. Yeah.
Exactly. But I talk to naked women every day about their sex lives, and there's just a lot of misinformation out there, and it's much more prevalent. It can come in waves, so it's not like it's really high after a baby, and after 2 or 3 children. It plummets for many people almost overnight when you're perimenopausal to menopausal. Yes, it can be related to relationships, and yeah, you've been with the same person all this time. Your habits may not be as romantic as they've been before, and now you're menopausal and you have children. There may be medications, yes, that you're taking. There may be relationship problems.
Sure.
And then there may be just mix match in terms of how frequently you want it. And then there's also, is it lack of libido or is sex painful?
Yep.
You don't want do something that's painful. And the decreased ability of couples to talk with each other about what's pleasing and what's not, maybe because you weren't honest and forthcoming with it at the beginning of the relationship and now are afraid to say something later. So just know it's very common. You are not strange. If you've not had an orgasm, or if you're not looking for more and more opportunities to have sex, you need to talk to your provider about it. And if that provider isn't going to talk to you about it, there are others who will.
I think that's great advice. Know that you're not alone, know that it is common, and know that I agree with you that a conversation with your obstetrician gynecologist or your internist is appropriate. And then thinking about how you could communicate with your partner those issues, because sometimes it is a communication problem about sex itself or just in general. I mean, there's, and in this day and age, so many of my patients have different schedules and their partners. Like she wants to go to bed at 9 o'clock with a book. He wants to stay up till midnight. And so like, sometimes it's a logistical problem. Sometimes it's a marital problem. Sometimes it's a vaginal dryness problem, but there are things you can do. There are techniques. It depends on, of course, what the underlying issues are. I commonly recommend to people, as I just said, like talking with your doctor, talking with your partner, figuring out if there's some medication you're taking that is dampening your libido. thinking about anxiety, thinking about body image, thinking about how those things may affect your sort of sexuality, yourself. And then, sometimes I just tell patients, if it's not a marital problem, it's not a hormonal problem, it's just time, you just have to schedule it. Schedule it like you schedule a Zoom call.
And it's actually okay to do
And it's
that.
okay, just schedule it. Make it, however often you want it to be. There's no rule, but schedule it and make it part of your life, because sex is good for mood. It's good for your relationship. It's good for, it's good for everything. It's really, what makes it, separates roommates from partnership in an intimate relationship. So it's important to address those issues if you're having problems. And there's no shame. These things can be addressed with your doctor.
Yeah.
So yeah, and I think that I'll also say that I don't know how you feel about Esther Perel, but she's written a great book called Mating in Captivity, Esther Perel, Perel, that I've recommended to many patients over the years. And basically the book is about, how to create desire, passion, and, as she would say, mystery in a long-term committed relationship. When let's face it, like I've been married for 20 plus years, like there's very little mystery, you know what I mean? Like, this person, so how do you reconcile like the lack of mystery and then the fact that mystery is required for desire and passion? So she has some really good tips in there. She's not a doctor, she's a PhD. Let me be clear, she is a doctor, just like Jill Biden is, but she's not a medical doctor, but she's really, really, really great with this subject.
Excellent. I'm going to read that. That actually sounds
good. But I think that at the end of the day, I also want to recommend your book again, because there are lots of good books out there, but yours is really, really nicely done, and I also love the illustrations. Mm-hmm. They're just so soothing and good.
So,
pull it up.
People can see it. Yeah.
Yeah, it's such a great book. Again, it's all you need to know and nothing you don't need to know about menopause, about being a woman. And I just think it's great. And I've read it. I've handed it out to a couple patients, recommended it widely. Anything else you want to go over before I let you go, or any last minute questions people might have?
I think we've had a very good discussion, a very balanced, wide range of things. But
we talked a lot about a lot of different things.
Yeah.
From sex to COVID and hot flashes. So if anybody missed parts of our talk, you can go back and listen. And then I'm also, for anybody here who follows my newsletter, I recorded it, and so I'll post it on my newsletter sometime next week. Heather, thanks so much for joining me again. It's always super nice to see you. I hope you have a quiet, relaxing weekend to the extent that is possible in the nation's capital before an inauguration that is making history. Sort of lay low.
Yes.
So thanks for coming.
Thank you, and thank you for having me. And I'm glad your family and all are well.
Thanks. You too. Okay. Bye, everybody. Take care.